Hello, we are here, Mr. Hetterfeld from Leiden University Medical Center. Hello, sir, welcome again.
Thank you.
My first question is, why do you study congenital anemia in the Netherlands?
That is a very good question. Congenital anemias are not very frequent in the Netherlands, but this has changed over the last 30 years approximately because of immigration. A lot of people from the Mediterranean area have moved into the Netherlands for economical reasons sometimes as refugees. However, this has changed the pattern of anemias in the Netherlands considerably. Because people having a partner also from the same ethnic group, they have a chance of having severely affected children, having beta thalassemia major or sickle cell disease. And that's why it's very important to get to know diagnosis of these diseases and of carriers. Because if you can identify a carrier on the hematological level, you have a possibility to explain to the carrier what is the genetic risk of having a child when the partner is also a carrier. In this way, we try to create a situation in which parents can decide about their offspring. For this, it's very important to instruct clinical chemistry labs, which are the first to see the blood of the patient, to tell them about what to look for in the diagnosis. So what kind of hematological parameters, the necessity to use HPLC and capillary electrophoresis to separate hemoglobin fractions, and to do DNA analysis to confirm the first two steps. In this way, we try to be successful in, let's say, telling the story about hemoglobinopathy and the risks for the people involved.
Okay, thank you very much. My second question is, what can be done about congenital anemia?
Well, it is a disease which is very difficult to treat. The state-of-the-art treatment is often lacking, especially in Northern European countries, because doctors do not have so much experience with it, even though it is improving considerably, I can say, in the Netherlands, as we have now specialized centers where patients with sickle cell disease and beta thalassemia patients are treated. However, still by treating, it's still a process of great burden, great pathological burden, and that is a burden not only to the patients but also to the family of patients. So there is still, I think, generally in the whole world, an interest in prevention strategies in which parents have can make a decision about their offspring. To let the parents make a decision about their offspring, they need to know that they are carrier. And that is the problem in the Northern European countries. Many people who are a carrier do not know that. And this knowledge is sometimes known to the clinical chemistry labs, simply because they do the diagnosis of the blood and they simply see it. However, we try to convince clinical chemists to report it to the doctor, because we think it is important information which the patients should get. Well, that is one thing. Secondly, in many Mediterranean countries, there is already a prevention program. People are sometimes screened premarital, just to see if they are a carrier, so that they can have the information before the lady gets pregnant. Another possibility would be during pregnancy. That is not a very good moment, because the lady is already pregnant and there are only few choices left. That is, cope with a severely affected child or having a medical abortion, which is of course a very heavy decision, ethically very difficult. So we think that to screen for carriers is the better option. And many Mediterranean countries are doing that, but not in Northern Europe.
Okay, thank you very much again. And do you have any advice for our guest?
I think the hematologists and the scientists in Turkey have advices for the Dutch colleagues. because they have much more experience with the congenital microcythemias. And I think this knowledge should be shared amongst people, doctors treating patients, and I think we can learn a lot about the programs which are done here in Turkey, but also in Greece and Italy, to detect carriers and to inform carriers about their genetic risk.
Okay, thank you very much again.
You're welcome.
We are glad to have you here. Thank you very much for your interviewing with me.
Thank you.
Thank you.
Thank you.